Okay, let us continue. Raise your hand if you're able to hear me clearly. Okay, that's good enough. So we were on the circulation for the primary assessment, and the circulation involves certain things that you must cover. So you need to identify whether or not your patient is bleeding and address that. You need to check the pulse. Patient is communicating, peripheral pulse, not communicating, central pulse. And we want the rate, rhythm, and strength of that pulse. When we are obtaining the pulse rate, we will count the pulsations for 15 seconds multiplied by 4. If you're not comfortable with your 4 times table, count it for 30 seconds multiplied by 2. If it's irregular, count the pulse for a full minute. Patient has an irregular pulse, it's an indication that they might have an abnormal heart rhythm. For the rate, that's the rate. For the rhythm, you are looking at the consistency of the pulse. Is it regular or irregular? For strength, is it strong or weak? And a very strong pulse may be an indication of a blood pressure that's elevated. Excessively strong pulse, a very weak pulse may be an indication of a blood pressure that is low. So that's a pulse. You will look at the skin color in the palms. If you see changes in the palms, you look for it centrally. So is a patient pale? Is a patient cyanotic? Do you see yellow skin, excessively flushed skin? Go ahead, Mr. Mackenzie. Go ahead. Go ahead, Mr. Mackenzie.
I'm sorry about that, sir. It was an error.
Okay. So you look for skin color in the palms. If you see signs of discoloration in the palms, you look for it centrally around the lips or under the eyelids. You will feel the temperature of the skin on the forehead or the core of the body. Does a patient feel warm? Is a patient cool and clammy? Is a patient diaphoretic, which means they are sweating profusely? Are there signs of shock present? You can check for signs of dehydration by just twisting the skin on the forearm for adults. If it remains twisted, that is an indication of dehydration. For your geriatric population, you use the skin on the chest. And for the pediatric population, you look at the spaces between the fontanelles. Are they depressed or bulging out? If it's depressed, then the child is dehydrated. They're bulging out, that's overhydration. Capri fill, more reliable tool for the pediatric population and the adult. You're squeezing the blood out of the capillaries, should take less than 2 seconds. Return. If it's delayed, there's a circulation problem present. So that would be a thorough circulation assessment. Once you have completed your ABCs, then you need to decide if you have a patient in which a rapid scan is indicated, or you have a patient in which you need to focus on a specific area or specific system. So perform a rapid scan. Scan the body to identify injuries that must be managed or protected before the patient is transported. And this will take 60 to 90 seconds to perform. It is not a systematic or focused physical examination. So you're doing a rapid head to toe. You're feeling the patient from head to toe, and you're trying to identify if there's any injuries that you need to address before you package your patient for transport. And at this time, we're looking for DCAP BTLS IC. So DCAP BTLS, the D represents deformity, the C represents contusion, the A is an abrasion, the P represents punctures, penetration, and paradoxical motion. The B is for burns, the T is for tenderness, the L is for laceration, and the S is for swelling. The ICI is for instability, and C is for crepitation. Crepitation is when bone ends under the skin rub together when they're broken. So you're using your DCAP BTLS. Now you can do a rapid scan for a trauma patient, and you can do it for a medical patient as well. You need to know when it is necessary. So let's start with the trauma patient because it's a little easier to determine for your trauma patient. When your mechanism of injury will determine if you need to do a rapid scan for your trauma patient. So regardless of your trauma patient's ability to tell you what's happening, the mechanism of injury determines if they get a rapid scan. Once you have a trauma patient with a mechanism of injury that is diffused, it means that your patient requires a rapid scan. So if I have a patient that was coming down a stairs, lose their balance, catch the railing of the stairs, and twist their ankle. So all they're complaining of is the pain in the ankle. That's a localized mechanism of injury. So a rapid scan wouldn't be needed for this patient. What would happen is we would complete LOC, airway, breathing, circulation, then we focus on the ankle that is injured. So a rapid scan wouldn't be necessary. If the same patient in a different scenario coming down the stairs, lose their balance, try to catch the railing, miss, roll a couple times, hit their head, end up at the bottom of the stairs, might be responsive, might not be. Sorry, might be unresponsive, might be responsive. The mechanism is now diffuse. So the possibility for multiple trauma exists. This patient must get a rapid scan, and we are taking spinal precautions until it is ruled out. So the assessment would be LOC, airway, breathing, circulation, rapid scan from head to toe, get the patient on a spine board, secure them appropriately, get them to the back of the unit, follow guidelines for spinal motion restriction. So that's the trauma patient. So what determines the rapid scan for trauma is a mechanism of injury. If it's a diffuse mechanism of injury, rapid scan is necessary. It's a localized mechanism of injury, no rapid scan is required. Focus on the injury. Full stop. For the medical patient now, to determine if you do a rapid scan for a medical patient will be based on the patient's ability to tell you what is happening. So if I have a medical patient and that patient can tell me that I've been having breathing problems for the past 15-20 minutes now, and I have a history of asthma. My assessment will be ABCs. So it's ABCs. Then I focus on the system that is being affected, right? So a rapid scan wouldn't be necessary because this patient can clearly tell me what is going on. So I would need a rapid scan for that patient. ABCs is a must. I will consider the history, the vital signs, and then focus on the system being affected. If I have a medical patient that's found at home unresponsive by family members, and I arrive on that location, the patient cannot communicate to me. The patient is in bed, and the family members are not able to tell me clearly what has happened to this patient, and this medical patient would get a rapid scan. So it would be ABCs, rapid scan, and the rapid scan that you do for a medical patient does not only focus on trauma. So you're thinking about trauma and medical problems. So I'm looking for DCAP BTLS, but I'm also looking for signs for medical condition. Does the right side of the face match the left side? Is there signs of rashes or abscesses on the skin? Is the pupils reacting appropriately? Is there unusual odors coming from the breath? Right? So I'm thinking about medical clues. Are there track marks on the patient's skin, which is signs of drug abuse with syringes? Right? So you're looking for medical clues and not just traumatic injuries. And once we have a patient in which we cannot get adequate information, medical patient, doesn't have to be exclusive to medical patient. Any patient that you're not able to get appropriate information from, or bystanders or family members not giving you adequate information. When you're doing your vitals, make sure it include pupil reaction, pulse oximetry, and blood sugar reading. So that's a rapid scan. And again, ensure that you know when to do a rapid scan for a trauma patient and when to do it for a medical. So I'm going to repeat it one more time. For the trauma patient, we use the mechanism of injury. Once the mechanism is considered to be diffused, that patient must get a rapid scan. And once the mechanism is diffused, we're considering C-spine complications. So we'll treat that patient as if the patient has a spine injury or spinal injury until it is ruled out. For the medical patient, it is the patient's ability to tell us what is happening to them. If they are not able to tell us clearly what's happening to them, then a rapid scan is going to be required, but we're not only focusing on trauma. We're looking for medical clues that can give us an idea of what is happening. If the medical patient can tell you clearly what's going on, then your assessment will eventually focus on the system that is being affected. If the patient, any patient cannot tell you clearly what's going on, or bystanders or family members are not giving useful information, you need to ensure that you look at your patient carefully and you include pupil reaction, pulse oximetry, and a blood sugar reading in your vitals. Now, after we have completed the LOC, airway, breathing, circulation, and rapid scan or focus, depending on which one is necessary, you now need to determine the priority of your patient. Right now, I always tell students, after you complete your ABCs and determine if you need to do a rapid scan or focus, you should know a few things at this point. You should know, well, let me put it back. Let me reverse a little bit. After you complete your ABCs, you should know what is your patient's GCS at this point, Glasgow Coma Scale, which we'll talk about later on in the chapter. So you should know what your patient's GCS is. You should know if you need to do a rapid scan or focus on the patient, and you should know the priority of your patient. Is it a load and go patient, or is it a stay and play patient? A patient becomes load and go when they are unstable. So if the patient presents with a problem that you cannot fix completely in the field, that's a load and go patient. If it's a patient in which their ABCs are stable and the injury or illness is not extreme, or the injury is localized, we can stay and play and then package for transport. But once ABCs are compromised, we need to load and go. And it doesn't mean you're gonna package a patient and drive like crazy. You're gonna package a patient as quickly as possible and go to the most appropriate healthcare facility that can handle that type of patient. So determine the priority of your patient care and transport. Primary assessment assists in determining transport priority. High priority patients include those with any of the following conditions: unresponsive, poor general impression, difficulty breathing, uncontrolled bleeding, responsive but not following commands, severe chest pain, pale skin or other signs of poor perfusion, complicated childbirth, severe pain in any area of the body. Now, in EMS, we have something that is referred to as a golden hour or the golden period. It used to be called the golden hour. It is now referred to as a golden period because there are a lot of circumstances that will have you on a scene for over an hour. Now, what the golden hour is, this is the time frame in which an incident occurs. EMS is notified and dispatched to the location. EMS arrives, provide assessment and management, and then package the patient, place the patient in the back of the unit, and transport that patient to the most appropriate healthcare facility. The ideal time for all of that to occur, we want that to happen within 1 hour or as soon as possible, because there are situations in which you can exceed the 1 hour depending on whether or not the patient is trapped on the scene or ALS is present and they can do what is necessary to fix the problem. So it can go over the 1 hour. Now, within that 1 hour, you have what is referred to as the platinum 10 minutes. So the platinum 10 is 10 minutes for you to assess ABCs, provide appropriate treatment, package the patient, and get the patient ready for transport. So that should not exceed 10 minutes. That is your goal. So you have 10 minutes to assess, manage issues, package, get them in the back of your unit for transport. 10 minutes. Within that 10 minutes, you have 4 to 6 minutes to manage anything that can kill your patient. So within the first 4 to 6 minutes or less, I will say 3 minutes and 20 seconds, within the first 3 minutes and 20 seconds, you should be able to address life threats. Within the first 2 minutes, 2 to 3 minutes, airway issues should be addressed. So time is critical to a patient that is critical, right? So time is very important. Now, transport decisions should be made at this point based on the patient's condition, availability of advanced care, distance of transport, local protocols. Now, let's say there's a motor vehicle accident in Halfway Tree. So there's a motor vehicle collision in Halfway Tree. You have medical associates that's nearby. You have UE and you have KPH. Patient is showing signs of head injury and possible spinal injury. Do I transport this patient to medical associates? Where do I transport this patient? That's a question. Why am I going to KPH? So why KPH? So I hear KPH, I hear UE. Why KPH, why UE? Come on, don't delay on the response. For the persons that are saying UE or KPH, why? Quickly. I don't want to waste time waiting on persons to give a response. You have made a response, state why. Yes, Mr. Roberts. Go ahead.
Sir, I don't really know the different hospitals and where them expertise is, but for the situation would I transport, well, if I would in that situation I would transport the patient to the hospital that me know say specializes or is best equipped to deal with those kind of injuries.
Okay. So that's a reasonable thought process. That's a reasonable thought process. So I'm okay with that statement. Right? So we have to be familiar with the capabilities of these 3 hospitals. That's the first thing. So when you're working in a service or an organization, you are going to be responsible for a primary service area. You need to be familiar with all of the medical facilities within that primary service area and what are their capabilities. And based on that, you will determine which facility would be appropriate for the patient. So it's not necessarily the facility that is closest, but more the facility that has the resources, whether that is in equipment and manpower to deal with that type of patient. So if you had transported this patient to medical associate, they don't have the capability to manage that type of patient. Eventually, they're going to tell you to take that patient to UE or KPH. So protocols must reflect this. This is not a decision for the crew members to decide on the fly. You must have a written protocol that clearly outlines which facility you will take this type of patient to and who is the medical officer or director at that particular location that you can communicate with if you're having issues in the field. So some service will have a medical director for the field operations and a medical director at the receiving facility. All right, now after we have completed the primary assessment is pretty long and detailed. and entails a lot of things. So that's going to be the most difficult part of the patient assessment algorithm to grasp. And I always tell students that it is also the easiest part of the patient assessment to practice. So it's very easy to practice a primary assessment. You just need someone you can communicate with and do your checks on. Now, after the ABCs, and we have made the decision to do a rapid scan or focus, and we know the priority and GCS of our patient and decide whether it's a load and go or stay and play, the next step is history taking. And we will always go for history taking first once the patient is communicating. So after ABCs, rapid scan or focus, and we determine priority. If your patient is talking to you, you get information first, then vital signs after. Patient not talking to you, you get vital signs first, and then you consider if anybody can give you any info or if the patient can give you any clues based on their presentation. So history taking provides detail about the chief complaint and the patient's signs and symptoms. It includes demographic information, the date of the incident, the patient's age, gender, race, past medical history, and current health status. You will investigate the chief complaint. So make introductions, make the patient feel comfortable, and obtain permission to treat. And it has become a habit for me, and I guess it's because of working in the States. I always ask permission to touch patients. So I don't just touch, I always ask for permission. It's a good practice. Ask a few simple and direct questions. Refer to the patient as Mr., Miss, or Mrs. using the patient's last name. Ask open-ended questions. If the patient is unresponsive, the patient information and clues about the incident may be obtained from family members present, a person who may have witnessed the situation, bystanders, medical alert jewelry, other patient medical history, documentation. Now, we have to obtain information on the presenting problem. So we need to get info on the presenting illness or problem. And we use the OPQRST mnemonic to get information on the presenting illness or problem. If the patient is complaining of pain, you will ask all the letters in the OPQRST. So if the patient is complaining of pain, we ask all the letters. However, and this is the part that y'all need to pay attention to now, the OPQRST is not exclusive to a patient who is complaining of pain. So it don't mean that it's only when a patient is complaining of pain that we will ask information based on the presenting problem. So there are certain conditions in which we can ask certain areas of the OPQRST. So any patient, especially your medical patients, will require you to obtain information based on the presenting illness. Now, onset, O is onset, so this is when the issue started. When did this start? Provocation and palliation. Provocation, is there anything that makes it worse? Palliation, is there anything that makes it better? Q is quality. So you will ask the patient, describe in your words, what it feels like to you. So tell me what it feels like to you in your words. Do not put any words in the patient's mouth. Let them describe it to you and watch their body language when they're describing. Region and radiation is R. So region, radiation. Region is where. Where exactly on your body is the discomfort? Where? Okay, that discomfort that you're having, do you feel it move to anywhere else on the body? Severity on a scale of 1 to 10, 1 being the least, 10 being the most, what number would you give this pain? And the T represents timing, and it's more the interval or consistency of the pain that we're looking at, and not specifically when the pain started. So timing is the discomfort or pain. Is it constant, or does it start and stop? And for your severity, if they tell you that right now it's a 9 or a 10, you need to find out, was it a 9 or 10 from the onset? So was it this bad from the onset, or has it gradually gotten worse? Now, pertinent negatives are signs and symptoms that you would expect to be present, but they are not. And I'll use a simple example. So I have a patient with a history of cardiac problems. The patient presents with palpitations. So he's complaining of palpitations, meaning his heart feels like it's racing and he's having trouble breathing. His pulse is irregular, but when I ask about chest pain, he's having no chest pain. So all the other signs point to this patient having some kind of issues with the heart, but the absence of the chest pain would be a pertinent negative. So based on the findings and the history I've gathered, I am suspecting that he might be having a MI, but he's not having chest pain. So that would be a pertinent negative. So it's something that I would expect to be present, but it's not. Right? And the elderly population and the female population, when they're having heart attacks, they tend to not complain of pain. They tend to complain of syncope, heart racing, indigestion, stuff like that. They don't increase pressure, not necessarily pain. So that is what we consider pertinent negative. It's something you would expect to be present, but it's not. Now, apart from obtaining information based on the presenting problem or illness using your OPQRST, you also have to obtain a sample history. Now, at this point, you would already know what your signs and symptoms are. So it's really ample you're obtaining at this point. You should know what your signs and symptoms are by this stage. And symptoms is what the patient tells you. Sign is what you can see, hear, smell, and what can be measured. So you're gonna ask your ample. Are you allergic to any medication, any food, any herbal supplement? That's the A. M, are you on any medications? Are you currently taking any medications? If the patient says to you, yes, then you need to follow up. Okay, which medication are you taking? Why do you need to take this medication? Is it available now? Okay, did you take it prior to our arrival? Has it worked? Right, so you need to know when to follow up on your questions. P, pertinent past medical history. Do you have any history of any medical problems? Have you ever been admitted to the hospital for any surgery? L, last oral intake. What was the last? Somebody's microphone is on. Who is that? So L is the last oral intake. You ask the patient, what was the last thing you had to eat? When did you have it? And events is what transpired leading up to the injury or illness. So what exactly were you doing prior to having the trouble breathing? So that's your sample or ample history. So you want to do two set of questioning. You want history of the presenting, connection went down. All right, I am back. Sorry about that. My connection went for a bit. Are you able to hear me clearly? Just quickly indicate by raising your hand and I will. All right, that's good enough. That is good enough. So we were on the ample and I think I'm finished with that slide. All right, now critical thinking. You have to be able to apply critical thinking in your assessment. So that requires you to gather information or seek out facts. It requires you to do some evaluating and you're considering what the information means and you need to synthesize. So you need to be able to put all this information together and then come up with a plan for managing a patient in the field. Critical thinking starts from anatomy and physiology. So that's where it starts from. You have to have a solid foundation in anatomy and physiology. That is a must. Then you need to understand pathophysiology. And pathophysiology is how the patient will present to you in the field. So what are the signs and symptoms you will be looking for if this patient presents in the field? That's pathophysiology. And it is what you also treat. So once you're able to identify the pathophysiology, then you need to know the sequential approach to manage that problem. Once you have all three elements, strong anatomy and physiology with the patho, you're able to recognize the patient presentation, you're able to sequentially manage the patient appropriately, then you will have strong critical thinking skills. And that requires commitment to your craft. So it requires commitment to the craft. Right now, we have, I would say, about 31 students in the group. And within, if all 31 students are successful, within 3 months, everything that I taught you, more than 90% of it, will be gone if you're not putting it into practice within 3 months. Within 2 years, out of this group, I might see maybe 5. Well, let me say, yeah, maybe 5 persons from this group might return 2 years from now to do a recertification. And the persons that do not return within the next 2 years will be working in the field uncertified. That's the trend in Jamaica. That's what I've seen over the 20 years of working here in Jamaica. Now, if you go through a training to apply a particular approach and assessment and management, and you are not staying up to date with the procedures, and you're not growing as a provider, then naturally your critical thinking skills will decline over time, and the patient will suffer from that as a result. So poor critical thinking skills lead to poor care administered to your patient. So it's something that you have to be dedicated to and committed to stay on top of your game. Constantly cover research that is being covered in your field, go to workshops, go to conference, get your CMEs, stuff like that. That's necessary to develop your skills as a EMS responder, especially if you're in an organization where you're not using all of your EMT skills. Now, taking history on sensitive topics, we kind of touched on this when we did documentation. So you have your patients who use alcohol and drugs. Signs may be confusing, hidden or disguised, so they might not give you accurate information. The patient may deny having any problems. History gathered may be unreliable. Do not judge the patient. Be professional in your approach. Then you have your physical abuse or patients that can be violent. Report all physical abuse or domestic violence to appropriate authorities. So law enforcement must get involved once there is physical abuse or violence involved. Do not accuse, instead immediately involve law enforcement. Sexual history. Consider all female patients of childbearing age who report low abdominal pain to be pregnant. Inquire about urinary symptoms with male patients, and when appropriate, ask all patients about the potential for sexually transmitted diseases. Your silent patient, you need to be patient with this patient. So patience is extremely important. Use close-ended questions that require a simple yes or no. Consider whether silence is a clue as to what is wrong with the patient. Then you have the overly talkative patient, and it may be because they have consumed some type of stimulant. So they might be overly talkative because they had too much caffeine, which is a stimulant. They might be nervous. They may have taken cocaine, crack, or methamphetamine. All of these drugs are stimulants, and stimulants increase the functions within the body. Heart rate, I could go up, breathing, and I could go up, stuff like that. There might be underlying psychological issues. Then you have your patient with multiple symptoms, and this is going to be more common in your geriatric or elderly patients. Prioritize the patient's complaints. You may have to triage all of their complaints to find the one that is the most serious and focus on that particular problem first. Then you have the patient that is anxious. Some anxious patients show signs of psychological shock. They might appear to be very pale, which is pallor. They might appear to be sweating excessively, that's diaphoresis. They might be having shortness of breath. They might appear with numbness in the hands and the feet, which is unique to patients having a panic attack. They can complain of dizziness or lightheadedness or loss of consciousness. Anger and hostility. Friends, family, or bystanders may direct their anger and rage towards you. Remain calm, reassuring, and gentle. If the scene is not safe or secured, get it safe or secured. Intoxication. Do not put an intoxicated patient in a position where he or she feels threatened. The potential for violence and physical confrontation is very high with these patients. Maintain your safe space, as I like to call it. And if we're dealing with aggression, we don't allow the aggressor to square up with us. If they square up with you, then they can hit you, and they can hit you pretty hard. So always set yourself in a position where they have to set themselves before throwing a strike at you. Once they have to follow you to set, then you have the advantage if you need to defend yourself. Alcohol dulls a patient's senses. Then the crying patient. A patient who cries may be sad, in pain, or emotionally overwhelmed. Remain calm, be patient, reassuring, and confident, and maintain a soft voice. Depression, among the leading cause of disability worldwide. Symptoms include sadness, hopelessness, restlessness, irritability, sleeping and eating disorders, and a decreased energy level. Be a good listener. Then you can have patients with confusing behavior or history, and there are a lot of conditions that can cause that. So conditions such as hypoxia, stroke, diabetes, trauma, medications, and other drugs could alter a patient's explanation of events. The older population, they will have dementia, delirium, and Alzheimer's disease. These are conditions we will talk about more when we cover geriatric emergencies. Then you can have your patient with limited cognitive abilities. Keep your questions simple and limit the use of medical terms. Be alert for partial answers and keep asking questions. Rely on the presence of family, caregivers, and friends to supply answers. Cultural challenges. Do not use medical language. Patients may prefer to speak with a healthcare provider of the same gender. Might not be possible in all cases. Gain the assistance of the patient's friends or family members. Enlist help from healthcare providers of the same culture or background if possible. Language barriers. An interpreter may be necessary. If you can get one through your service, request them. If not, determine if the patient understands who you are. Keep questions straightforward and brief. Use hand gestures. Be aware of the language diversity in your community. Hearing problems. Ask questions slowly and clearly. Use a stethoscope to function as a hearing aid. Learn simple sign language to help with communication. Use a pencil and paper. And as I said, a lot of what I'm going through now are things that were a part of the communication and documentation chapter. Visual impairments. Identify yourself verbally. When you enter the scene, return any items that have been moved to their previous position. Explain to the patient what is happening in each step of the vital sign assessment. And that would be the end of your history taking segment. So the next two segments of the assessment is going to be secondary and reassessment. But this is where we will pause. So we're going to pause here.